Now, because you heard me talk about tracheostomy and their advantages, disadvantages, let's talk a bit more about them. They are made up of a curved tube. In the past, they were made up of metal, even silver. But of course, all of this has gone now, because all these tubes, by definition, will be single lumen. Now, tracheostomy tubes are generally, nearly always now, double lumen. What that means, there's an outer one, and there is an inner tube that you can remove and clean. Because if you don't have an inner lumen, if you have an inner lumen, you don't need to change the tube for about 4 to 5 weeks. If you don't have an inner lumen, you need to change the tube every 5 to 7 days. And if it blocks, the patient has no recourse. Whereas if the inner tube blocks, you can remove it, clean it, or even replace it. Whereas the outer tube is still there. So it goes off with disadvantage. In fact, hardly any person on a long-term ventilation now hardly ever has a single tube, a single lumen tracheostomy. And there are several diameters, depending on the patient's size and so on. It has to be chosen with an internal diameter that is wide enough so the person doesn't have a great deal of work to do to inhale air, because the narrower the tube through which the air passes, the more work has the person got to do. Can you imagine somebody narrowing your own trachea by, say, half? How much harder do you have to work to take a breath? Yeah, so it needs to be wide enough so you don't have a lot of airway resistance. The wider the tube, the less is the resistance, of course. But also, if it is too wide, then the person at some stage will need to speak. Okay, and without enough space between the tube and the trachea, air will not go past it for the person to speak. So it needs to be of optimal diameter, okay, to satisfy these. The tracheostomy tubes also come in 2 types, those with a cuff, which is a pillow of air surrounding the lower end of the tracheostomy tube, and that joins to a tubing to the outside where you can inject air through a syringe at enough pressure to occlude the lumen of the trachea. The people who have, say, disturbed conscious level or have problem with swallowing, so food or secretions can accumulate and then trickle from the throat into the trachea. So this largely, not completely stops it, but at least prevents particles from going into the lung. So the cuff is important, in particular in the early stages. The disadvantage of the cuff, of course, the patient cannot speak, and so you have to deflate the cuff if the patient wants to speak. There are other types of tracheostomy tubes that are cuffless. When people who require some-assisted ventilation but they have normal swallowing, and the chance of them inhaling something is sort of not high, okay? And of course, we must not forget that the cuff, once we inflated it, it will impact on the, behind it is the esophagus and the pharynx. So if we inflate it, it could cause dysphagia or difficulty swallowing. So that's again one of the other disadvantages of having a cuff. So there are the advantages, disadvantages to everything, of course. And of course, when we inject air into the cuff through the tubing, there's a manometer we can connect so we don't overinflate. Because if you overinflate, then you can put a lot of pressure on the wall of the trachea and cause actually damage to the lining. And of course, any damage will be followed by sort of cicatrization, and you will have permanent narrowing of the airway. So that must not happen. We must not allow that to happen, okay? Because it is an extremely difficult problem to solve, if at all. Some tracheostomy tubes have what they call speaking valves, Passimua valves, What are they? These are one-way valves. They allow air to enter one way. So if somebody has got a tracheostomy tube and either has a fenestrated or has a partially deflated cuff, air can the person can take air both ways through the normal airways and through the speaking valve. Okay, and of course when they so you have air entering into the two ways. Okay, and of course as the person tries to speak, the valve because the one-way valve is shuts, and the person can generate better speech this way. The inner tube of every tracheostomy tube is nearly always not fenestrated. Okay, but sometimes it can come fenestrated. It means it's got a hole at the back of it, the back of it. As we said earlier, because having tracheostomy has got its own problem, its own irritation, by itself it can generate more mucus production. So we have to have a mechanism of cleaning this chest, because people who require tracheostomy, who have neurological damage of some kind, will have a problem with the cuff reflex, as we know. And whatever we do, we still need to access that chest to clean it. Now there's two ways of doing that. There is a machine called MIE, acronym for Mechanical Insufflator Exsufflator. What that means, that it's a machine that actually connects to, it can be connected to a mask as well in people who don't have tracheostomy, but again, it's much better fit if it is connected to a tracheostomy. It reproduces the cuff reflex. Basically, it inflates air at somewhere a pressure of between 30 to 60 centimeters of water, and then sucks it out at between 36 centimeters of negative pressure. So, which is effectively what the cuff reflex is. But of course, it never replaces your cuff reflex. But it can get rid of most of the secretions accumulated in down to about 6 divisions of the bronchial tree. Below that is not as effective, and therefore we have to combine this with another procedure, which is catheter suction. The catheter has to be, again, the people will have to be trained on how to handle the catheter suction effectively, so the suction does not cause damage to the lining. You apply negative pressure, and doesn't cause irritation, because as you put it through the tracheostomy tube, the tip can hit the area called the carina, which is the area where the trachea divides into two divisions, two bronchial, and it can hit it. It's lying this way, so it hits it vertically, and that can cause a lot of irritation. So it needs to be handled gently, and the person handling it must be wearing a sterile glove. The other glove that is handling the dials of the suction machine may not need to, it needs to be clean but not sterile. But the one that is handling the suction catheter itself has to be sterile glove. That can generate a pressure of about 120 centimeters negative of mercury, negative pressure. So it has to be, the person using it has to be very careful, and when it's withdraw 1 centimeter at a time, and then stoppage. And during that time, one has to bear in mind that the person is not breathing, so the total time of the suction really shouldn't be exceeding 20 seconds. And before you start it, the person has to be oxygenated with an ambu bag 5 or 6 times, so build-up of oxygen in, so the period that he's not breathing while you're suctioning can protect him. And there are going to be, you can see here, contraindications of that, of suction, under what circumstances you must not do it. And the same thing applies for the insufflator, exsufflator. generally speaking, anything, as you're pushing air under pressure, anything that's likely to damage the lung from high pressure, you need to avoid. So say somebody who's got pneumothorax, has got a bullous disease of the lung that the pressure can burst it open, fractured ribs, and so on. These of course, you must avoid doing what can exacerbate the situation. So you need to be careful when you use these machines. They are very useful, but used in the wrong indication, they can be more damaging.